Okay, now we're going to go to our kickoff session, which is the population health priorities in Texas. I'm going to introduce our speakers, and then we're going to have a fireside chat over here. Dr. Boerwinkle is the Dean and the M. David Lowe Chair of Public Health at UTHealth Houston School of Public Health since 2016. He joined UTHealth Houston in 1986 and chaired the Department of Epidemiology, Human Genetics, and Environmental Health from 2003 to 2015. He directs the Human Genetics Center and the Brown Foundation Institute for Molecular Medicine at UTHealth Houston and holds the Kosminski Family Chair in Human Genetics. Boerwinkle is also the Associate Director of the Human Genome Sequencing Center at Baylor College of Medicine. He's authored an unbelievable over 1,200 scientific publications, and his research focuses on genome variation and its impact on health and disease. His work includes pioneering genome-wide analysis for cardiovascular disease risk factors, aiding in drug development, and polygenic risk scores. Please join me in welcoming Dr. Boerwinkle. Sorry about that.
Thank you, Maria. So I struggled a little bit about what I was going to say at the podium. You know, there's a tendency when you're asked to give an introductory or keynote talk to either do one of two things. Is first, you sort of come up here and you're old and you celebrate your own career going backwards. It's a little weird first, and it's not very interesting second. The second thing is you pontificate about the field, which actually can be interesting, but I'm not sure it's appropriate for today since we're bringing people together to form bridges and actually get something done. So instead, what I've done is I took the word priorities very seriously and tried to come up what I think are top priorities or examples of top priorities for population health. And there are also things that I believe in a relatively short time we could accomplish. We could do together here at UTHealth with our clinical and community partners. So I'm going to tick off 4 things relatively quickly, and then we can expand on them later. Number 1, I think we need to build and rebuild trust in public health and in healthcare, both of them. There's a tendency to think that a lot of that mistrust that emerged during COVID, but I don't think that's true. I think the seeds of the mistrust preceded COVID. And we have, people shunning proven treatments. We have people shunning vaccinations in favor of actions that are not based in evidence. We've made cuts in proven public health programs. We have violence in our hospitals against healthcare professionals. And I would also call your attention to a recent assassination of an insurance company executive as an example. And the sad thing about the latter is actually applauded in many corners. And so we really need to work on, telling our story, getting our story out there of all the good things we're doing. And I don't just mean heroic medicine. I mean everyday public health and medicine. We also need to get our story out despite the echo chambers of modern media. We basically just talk to ourselves, and we need to get our stories out to those that can hear it and those that can make appropriate change. So I would say that's priority number 1. Priority number 2, I think will surprise you, coming from the Dean of the School of Public Health. I think we need to develop a sustainable population health strategy for GLP-1 receptor antagonists. Having been in the School of Public Health for a long time and watched a lot of the smartest people I know, a lot smarter than I am, trying to work on weight loss, weight control, good diet, starting in young people, it's frustrating. It's frustrating, the progress or lack of progress. But for most people in this room, these compounds that the evidence is suggesting work, your insurance isn't going to pay for them unless you have serious comorbidities. And I would suggest we need to come together and have a true population perspective of these medicines. Granted, they're given one patient at a time, but the discussion isn't right about what are we doing in terms of moving the needle on chronic disease prevention with these drugs, particularly since they have such beneficial impacts on comorbidities and also behavioral changes, particularly substance abuse changes such as alcohol abuse. That it shocks me a bit that my insurance company won't pay for them. I'm not picking on my insurance company. It's just I happen to have the microphone. But they'll pay for my bypass surgery, once I have an MI, or they'll pay for, a prosthetic leg because, I've had an amputation because of my out of control diabetes. So we're just out of whack a bit, I would say, in terms of a population health strategy for these important weight loss strategies. Number 3, I think we need to capitalize on Secretary Kennedy's focus on chronic disease prevention to develop and launch mental illness prevention strategies and campaigns. We're not providing the necessary help until a person is unable to function in either a school or in society. So I challenge all of us to think about, and Jair's here, Dr. Suarez is here to help lead us in this effort. What is the cholesterol equivalent, or what is the colonoscopy equivalent to mental illness? And, what are the root causes, and what are the early signs? I mean, real early signs. And what are the prevention levers that we can pull to help stem the downstream consequences? We tend to focus on the person who's laying on the street corner. But then it's late. It's way too late. We need to think about prevention way upstream. I mean, way upstream, and thinking about what we can do. Again, it's a challenge, it's a challenge for us, not all of us. Finally, this is number 4. We need to understand the threats to a lifelong population health in the 21st century. The last large children's cohort studies in this country, and I've ticked them off, and please correct me, you could fill in. The study in Bogalusa, Louisiana, Muscatine, Iowa, and Tecumseh, Michigan. To my knowledge, those are the last national children's cohort studies that have been carried out. They were launched in the 1960s and 1970s. And I suggest you just pause for 5 seconds and think about a kid in 1965 versus a kid in 2025 and their life experiences. We just do not have one, period, as a country. We don't. In 1965, there weren't iPhones, there wasn't the internet. We still had an industrial society, not a technology-driven society. Congress mandated a national children's study that was launched and summarily canceled because of just bureaucratic morass. I once spoke to introduce a genetics component to the National Children's Study to their steering committee. This was their steering committee. There were about 800 people in their steering committee. You're not going to get any work done with 800 people in the steering committee. That's a recipe for disaster, and it was. The All of Us program's on life support today. And it had a children's component, but it's been paused. So I would challenge us, and Texas is an outstanding place to launch this. In fact, I would say Texas could be a model for the rest of the country. And a Texas-wide cohort study that includes children, I think, would be of great benefit to Texas, and it could be a great benefit to the country. And UTHealth Houston and Southeast Texas is the right place to start it, and then we could expand it out to the rest of the state. So our picture of childhood chronic disease risk development is just out of date. In fact, it's so out of date, I would argue it's almost non-existent. And so again, what I try to do is pick 4 things that I think are important priorities, but they're important priorities that we can work on together to accomplish. So Maria, thanks for getting us together, and I'll be quiet and have a seat.
All right, and we'll have a chance to dig into some of those topics that you raised in just a moment, Dr. Boerwinkle. All right, now I'd like to introduce Dr. David Lakey. He's the Vice Chancellor for Health Affairs and Chief Medical Officer at the University of Texas System and a Professor of Medicine at UT Tyler Health Science Center. Dr. Lakey was the Commissioner of Texas Department of State Health Services and held leadership roles at UTHealth Center at Tyler previously. He sponsors the Texas Health Improvement Network and presides over the Texas Child Mental Health Care Consortium. Please join me in welcoming Dr. Lakey.
Thank you, Maria. First, it's a privilege to be here, and thank you, Dr. Boerwinkle, for your comments. I approached this just a little bit differently, but I think complimentary. It is an amazing privilege to be here during National Public Health Week. And so again, thank you all for doing this. And I want to take a minute of recognizing this institution for the tremendous contributions it's made for over 5 decades, trying to improve the health of the city, the state, the nation, and internationally. It really has been incredible work. I think before we discuss specific public health priorities, I think it's important to level set. I think it'd be helpful to reflect upon Texas as a whole, where we are, and what data tells us about how we're doing related to health in Texas. I think this state is a pretty amazing state in many different ways. You know, we are larger geographically than any European country, if you exclude Russia. I have 2 slides that I use in a lot of presentations. One, I put Texas in Europe, and you can see it covers Germany, part of France, part of Italy, Switzerland, et cetera. The state's huge. I have another slide that I use when I'm talking to people in other states, where I have New York, New Jersey, Vermont, New Hampshire, several other states, and it covers about 40% of the state of Texas. I think it's important for us to remember how big the state is, because policy in El Paso is going to be different than in Texarkana or Houston. I think many of you know that if you're standing in El Paso, San Diego is closer to you than Houston. If you're standing on the northern border of Texas, the Canadian border is almost as close to you as McAllen. It's a huge geographic space. You know, if we were an independent country, we would rank 8th related to our GDP. We are the most urban state in the United States. 4 of the 10 largest cities in the United States are in Texas. And I would also argue that we're the most rural and frontier state in the nation. We have 8 counties with less than 1,000 people that live in them. We have 91 counties that have less than 10,000 people in them. And so you have this diversity of size. We're currently in the largest medical center in the world. However, at the same time, many of our cities struggle to have just basic primary care. And as we continue to lead, we also continue to lead in population growth. I was looking at some numbers when I became Commissioner of Health in Texas in 2007. The population of Texas was 23.8 million people. We're now 32 million people. We've grown by a third. Basically, we've grown by 8 million, which is the population of the state of Washington. That state, basically, population has been added to our state. And about 1 out of 10 babies born in the United States are born in the state of Texas. I have found over time that many people misjudge the overall health of the people of Texas. Some people are overly optimistic, think everything is great. Other people, I would say, are overly pessimistic. Everything is terrible in the state of Texas. And I have found over time that the truth is, like a lot of things, in the middle. And so I think it's important for us to look at facts and data. And one of the tools that I use looking at health is something called the America's Health Rankings. How many people are familiar with America's Health Rankings? So I'd say about 20 to 30% of the people here are familiar with this. And they use about 87 different metrics. It's or variables, and then come up with a composite score related to how you compare to other states. There's some statistics that Texas does very well on, and there's some statistics that we do very poorly on. And I think we need to confront that openly. For example, if you look at our smoking rates and our overdose rates, these are some of the lowest in the nation. Likewise, if you look at racial disparities related to residency or racial disparities related to premature death, we do better than many other states. And in that last measure related to premature deaths, racial disparities in premature deaths were 11th best in the nation. We also do better related to adverse childhood events. We seem to exercise more, eat more fruits and vegetables than average of people in other states. And you look at health outcomes in Texas, they would rank us 24th in the nation. On the other hand, there are areas in health statistics that we do poorly, and we're using their metrics near the bottom. Access to healthcare, adequacy of our healthcare workforce, insurance coverage, preventative clinical services such as colorectal cancer screening, childhood immunizations, high school completion rates, HPV vaccination rates are some of the examples of where we're near the bottom compared to other states. Now, I've watched these data for the better part of 20 years, and there's some fluctuation, but we always end up ranked somewhere between 32 and 39 related to their composite score. And so we're not at the top, we're not at the very bottom, but we still have a lot of work to do. I also believe that it's important to recognize that health outcomes still are very dependent upon where you live and your ethnicity and racial background in the state of Texas. There are variances in health statistics, things we call disparities, and they're real. For example, health statistics in Northeast Texas are significantly different than the rest of Texas. Back in about 2016, we were part of a group that put together a health status report for that region of Texas. If it was a standalone state, it would rank 44th in all-cause mortality, 48th in cancer, 50th in stroke. It is much more like Mississippi or Louisiana than the rest of the state, and a lot of that's driven by tobacco and lower educational attainment. You know, it was interesting when we put together that report, the people that would carry it around was the business community, the people that were part of the Chamber of Commerce, because they understood that the cost of business was directly related to health outcomes and the health of their community, and they weren't going to get businesses to locate in East Texas if they didn't do something to improve the health of East Texas. You know, in another analysis, we've mapped out life expectancy and infant mortality by ethnicity and zip code, and it's clear from those analyses that there's a clear distribution for each race based on the zip code for infant mortality and life expectancy. Let me just give you a couple examples. You know, the overall infant mortality rate's about 5 in the state of Texas. Hispanic individuals seem to do a little bit better, but I can show you zip codes in San Antonio where it's 12. So about twice as much as the state average. I can show you zip codes up in Longview in a rural area where the white infant mortality rate's about 12. Again, more than 12 is more than 2 times the state average. And in this city, I can show you a zip code in the southeast area of this city where the black infant mortality rate is 3. It's half the state average. And I can show you a zip code up in northeast Houston where the infant mortality rate's 30. So 6 times the state average. So with that background, just trying to level the playing field of kind of where we are related to health, here are some of my priorities that I think we need to work on as a state. I think one of the key things is working on access to high quality health care, especially primary care. You know, there's a clear relationship between primary care and life expectancy. There's been studies that have shown that there's an increase about 51 days in the United States for every 10 additional primary care doctors per 100,000. I would note that 6 million Texans live in a primary care health professional shortage area. So I think as a state, we need to work on the availability of primary care. Jair, I'd put number 2, access to mental health care. And for any of us that have looked at the data, and again, I think this is consistent, Eric, with what you noted, we have a major challenge related to access to mental health care in the state of Texas. And it's really important. When I was commissioner of health, I came to the realization that one of the most important public health issues was mental health care access. Because if you're a young individual and you're struggling in school, you're less likely to graduate, you're less likely to go to college, you're less likely to be in a committed relationship, to be a father and a mother, to have a job, more likely to use substances, and therefore, I think it's a root cause of many of the public health challenges we face in Texas. 50% of mental illness begins before the age of 14. And so we need to identify individuals early and get them into treatment. If you look at why young people die, suicide is the second leading cause of death for them. Yet 61% of children with depression receive no treatment. And we have about 350,000 children in Texas that have severe mental illness. And again, we have about 13 million Texans that live in a health professional shortage area. I think it's been nice to look and work with the legislature over the last decade and a half and seeing the investments that they have made. Again, if you look at the investment, they've put in almost $12 billion into mental health services right now, which is an increase of $5 billion or a 77% increase since 2005. And you see that work taking place across the state, in state hospitals, access to services. And I think that's why the new School of Behavioral Health here at UTHealth Houston is going to be so important, because we need that workforce. I think, and Eric, I'd agree with you related to chronic disease prevention. I think that's really important. We have known how bad tobacco is on our health my entire life. The Surgeon General's report, first report came out in January of 1964, same month I was born. So literally my entire life, we have known that smoking tobacco is horrible for your health. The cancer, the strokes, the heart disease that are related to it. We've decreased our tobacco use by 67%, yet we have 28,000 Texans that still smoke. And that costs the state a little over $10 billion a year. So it kills 28,000. We have 4.7 million Texans that still smoke. And again, if you talk to them, about 2/3 of them would want to stop. And I would put on the list also the challenge that we have with obesity in the state, with 35% of our adults with obesity. And all of us know the challenges with obesity, that the chronic disease, the heart disease, cancer, diabetes related to that. And again, I think that's a key role that this institution is playing with your Michael and Susan Dell Center for Healthy Living and the SPAN data and the other work that Deanna Hochschild is leading. And again, trying to figure out how can we be smarter with nutrition and exercise. We have also worked on birth outcomes as a state. I think that's an important area for us to continue. Again, when I look at the data, I would remind myself that Black mothers die twice as often in childbirth as white women do. And it's an area of disparities and an area that we need to continue to work on. And along with that, the access of maternal health care in rural Texas, in the maternity deserts. And there's a lot of things taking place. Again, UT School of Public Health now houses the Texas Collaborative for Healthy Mothers and Babies. The state has the Maternal Morbidity Task Force that is part of it. I was excited that last legislative session, they extended Medicaid to a full year postpartum. I think all those things are important as we address this issue. I think it's easy to forget infectious disease and say that the age of infectious disease is over. But I would remind us right now that we have a congenital syphilis outbreak going on in the state of Texas. That these sexual transmitted diseases and other germs, they don't care about the policies that are taking place in Washington. They will spread from one person to another. And again, if you look at the data, childhood vaccination rates, we would rank 43rd, HPV vaccination rates, 40th, adult flu, 47th. I think a priority for the legislature is rural health. And I think we need to figure out how do we better address rural health care in the state, using technology such as telehealth, figuring out how do we encourage people to live in these areas, because it's different, it's hard to keep these hospitals open. One thing I think all of us need to watch coming out of this legislative session, and the legislators are saying it's a priority, is dementia and Alzheimer's disease. There's going to be a huge initiative from the state of Texas, I believe, called DPRIT, the Dementia Prevention Research Institute of Texas. They have set aside $3 billion for Texas to do something significant with it, such as we've done with cancer under CPRIT. My next item, I know it's kind of a long list, but I think they're important. When I was commissioner, I came to the realization that I needed to be prepared for one event of national consequence per year in the state of Texas. There will be another Harvey. There will be another Hurricane Ike. There will be another H1N1, Ebola, or whatever new infectious disease that's going to be out there, and we're going to have to be able to respond. And that is just life, and we need to be prepared for those type of events. And when we don't do well in handling those events, we lose our credibility to address all those other things that are important. Last two, and again, I know it's a long list, the non-medical drivers of health, I think, are really important. And Medicaid is looking at how can we be smarter at addressing those, the housing, transportation, medical legal partnerships, which type of programs actually work. And finally, I would put on my list, and again, because I worked in government, that the public health infrastructure, that the people that work in governmental public health at the state and local level, the data systems that we have, so we're not faxing data back and forth to each other, that you have real-time information so we can make smart decisions, laboratories that are up to date. There are unique things that the CDC laboratory does, the state laboratory does, that no one else does, that you need in place to be able to respond to what type of any kind of event that occurs. So Eric, I kind of took a longer list and maybe more governmental list to it versus very pinpoint that I think both of these need to work in concert if we're going to really improve health in this state that we live in. Thank you.
Thank you both. So I'm going to start off with some questions, and we'll have some discussion here, and then we'll open it up to the audience. You both covered several of the questions that I had. So, but I'm going to start with a question to both of you. How do you balance a statewide strategy of population health with the local context and local needs, especially when we're thinking about rural, urban, and other underserved populations?
Take it first.
So I think it's hard. Can you hear me okay? Microphone. So I think, having been commissioner of DSHS for 8 years, you learn that if you want to do something, you really have to work with partners. You can't solve all those issues in Austin. And there are different groups that have been put together to bring local health departments together, working with the state. Something that we've put together that many of you have been part of is the Healthier Texas Summit, where we try to bring people from across the state that are doing novel things and kind of share that information. I also think that if you want to drive policy, you have to become familiar with how legislation actually works in Texas and how you can be helpful or how you could be harmful in trying to help individuals craft good policy in the state. A lot of it comes down to budget, and will the dollars that go to the state flow out to communities? I think that's one of the misconceptions people have on the CDC, and they look at their budget. They don't realize that the majority of the tobacco dollars, the immunization dollars, a variety of other dollars in our state budget are passed through from the CDC, and then they pass it through to local communities. And so the stabilization of the CDC and those funds are really important as we work in public health in collaboration and partnership and leveraging the best talents. And again, in this state, there's a lot of really smart people across the state that if you bring them together can come up with really novel ideas. Eric?
Well, first, I 100% agree, particularly about the importance of having a stable, healthy CDC, because people don't realize that the impact is typically local. They think about federal programs as only federal programs. They don't realize the actual implementation is local. But then I'll add to it with a bit of a slogan of having a statewide vision, probably a statewide vision that comes from DSHS in partnership with many others. But again, it has to be a tailored local implementation. You know, what works in suburban, let's say wealthy communities in Dallas, Austin, Houston, wherever, may not be what's going to work, and border communities may not be what's going to work in a rural environment. So we have to be able to tailor implementation locally in partnership with local people who know those communities. And we can do that. I think, you know, one of the great things, and, you know, I love being here, is we can do that sort of statewide vision and local implementation. We've shown it to ourselves over and over again. Is it perfect? No. But is it effective? Yes.
Yeah, and my next question, and perhaps the response is similar, is how do we ensure that innovations that result from research, but also policy innovations reach those populations and communities that most need them?
Yeah, I mean, you know this better than I do, that often, I mean, I can step back a little bit. You know, often these innovations from, let's say, academia, where a lot of innovation does occur, but also in the private sector, there isn't that step to make sure it's implemented. And I think there's two problems, I would say. One is the lack of having good economic data about the implementation. That it not only moves the dial on healthcare or health or prevention, it makes good economic sense. It needs to have a sustainable part to the economically sustainable part to the implementation. I'd say the other side is we don't, I'll speak for myself, then I don't understand, pay attention to, or know how do we change behavior in a healthcare system? And who do we talk to? Who do we work with to change workflows within a clinic or workflows within a hospital? It's hard to change behaviors within the healthcare system. And I really think that's how important this kind of a meeting, and this kind of meeting is, to bring together expertise across our schools so we can learn how we can work with one another to foster that implementation.
I think a couple things. I think, one, we need to get better at telling the stories of what works. A lot of times you find good strategies in one community, but we don't necessarily share them, and we need to get better at doing that. And a lot of times, public health type people, they just need to rethink about how they tell stories and tell of their success. I also found kind of in Texas that a lot of times we do pilots, but we never take them to scale. And we need to stop doing that. You need to do a pilot, figure out if it's successful, take it to scale, and keep working on those types of things. And again, a lot of times that has to do with getting the financial resources to do it. But you know, that's why we need to work with legislators, and not during necessarily legislative session, but getting them out and talking to folks after the session, after they've had time to rest, and show them the good ideas. And you know, they want to improve health in our state. They may have a different strategy, but we need to work with them and figure out kind of nonpartisan, bipartisan solutions to improving health.
Thank you. And I think that many of the comments that you made, we're going to be hearing about some of that today. So how do you change systems? How do you leverage communication science, implementation science to answer some of these tough questions? So thank you. I'm going to ask you, Dr. Boerwinkle, a little bit of more of a specific question about genomics and precision medicine. How do you think that these sciences can contribute to population health strategies, particularly in a state as large and diverse as ours?
Well, so first I'll answer the question of how. I would say both of my examples are going to be in the pediatric space, particularly since we have two pediatricians here. I would say one is pharmacogenetics, workflows in pharmacogenetics, that the science is there and it's just rarely implemented. I'd probably say the best place that's implementing good workflows for drug-gene interaction is St. Jude's in their sort of pediatric cancer area, where there's a lot of innovation that can be done. The other area is in mental health, pharmacogenetics in response to a lot of drugs that are used to treat behavioral health issues. That would be one. I think the other big one is in the area, and I have to be honest, I can't figure out why we're not doing this as a society. We should be sequencing every kid in the NICU and PICU. The data, particularly for the NICU, is you save lives. You save this diagnostic odyssey for the family. You can't believe, these families will do anything to understand, what's wrong with their child who's in the NICU or PICU. And the third is in about 15% is be a reasonable number. They actually have relatively modest changes in, for example, diet, because it's an unknown inborn error of metabolism, which the kid can flourish. But if you don't understand what's happening, the rate of decline and ultimately death is shocking and depressing. So I would say those two areas are where genomics can make an immediate, again, cost-effective impact on population health, and we should be doing it.
Mm-hmm. And getting back to the previous comments, and then ensuring that those innovations don't actually increase disparities by making sure that they're available to all. Do you think that's possible?
Do I think it's possible? Yes, I do. Just because, again, the implementation has been shown to sort of, it's cost effective and it moves the dial on health. I think implementations that are not possible today, and I've got, unfortunately, real life experience in this, is implementations that basically stack up people that are at risk, but the healthcare pipeline can't take them in. The healthcare, there just isn't the capacity, and often that capacity is limited by finance, but not only finance. But so I think having, unfortunately, this is often in adult medicine where we use genomics to identify those at increased risk. Those with insurance, good private insurance, they tend to get taken care of. Those without tend to stack up, and that's not fair. It's not fair, and it's also dangerous. You have people that have known aberrations that may take their life, and they're waiting, and that hurts to see.
Thank you. Dr. Lakey, you lead the Texas Child Mental Health Care Consortium. What insights do you have from that work that you think can be sort of scaled and to improve behavioral health, mental health in Texas?
Yeah, and so thank you, Jair, for all the work that you were there from the beginning. And so the Texas Child Mental Health Care Consortium, I think it's a good example of how, if there's a real problem and if you get the right people in the room, you can come up with solutions. And so this was back in 2016, 2015, and we were looking at expansion of the state mental health hospitals. And if we're going to do that, how would academia play in that? I got the 1 minute thing. And so we got all this chairs of psychiatry and the state agencies and philanthropic organizations to work together on solutions. And when the legislature found out that we were doing that, they liked it. And they took that to scale. And so it does things related to providing telemedicine services to 78% of all the kids in the state of Texas, doing about 10,000 sessions a month. It's providing about 1,500 consults to primary care providers each month. It's developing workforce, and it's trying to solve the challenges we have. And all that's important work, but I think it's an example kind of from a public health coalition type approach that if you get the right people in the room, start talking and start solving real world problems, you can get investment from our legislature to do that. And you know, we're going to be approaching $350 to $400 million this biennium of resources. And we had 0 10 years ago.
That's great. Okay, I know we're out of time, and we're going to go see if anybody has any burning questions from the audience, but just very, very quickly, a sentence or two. What advice do you have for students and early career professionals who want to make a real difference in population health?
So I have found working upstream to be incredibly satisfying in my career. I got tired of taking care of the same preventable problems over and over and over again. I would round in the intensive care unit on another patient with a sternal wound infection that if they didn't have, if surgical things went right, or if they didn't smoke, they wouldn't be there. And counseling young women that they indeed were infected with HIV, and that if we didn't do things, their child would be infected. And being able to work now upstream to prevent those problems in the first place has made my career much more rewarding than it would have been if I continued to see one patient after another in a sick healthcare model.
Thank you.
First, I agree with David. The other would be, particularly now, follow your passion. Follow your passion. There's a lot of noise out there. You know, I'm living it now as, you know, putting on my dean hat. A lot of students are wondering what's going to happen after they graduate or what, et cetera. Is follow your passion. You know, there is enormous public health needs. There's enormous infrastructure, going back to one of David's priorities. There, excuse me, enormous infrastructure needs. And there's great, I would say, a great work ethic in Texas. So follow your passion, follow partners, make partnerships, and I'm very optimistic about the future of population health.
Great. Do we have any questions? All right. Well, thank you so much. Please join me in thanking our speakers.